Good afternoon, everyone, and welcome to this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. In today's webinar, we will learn about the management of Glanzmann's thrombasthenia. This webinar is being recorded and will be available to the community on the NBDF website shortly after the webinar. We encourage you to ask any questions you may have during the webinar by using the Q&A feature at the bottom of your screen. We will follow these questions as they come in, and then after our speaker's presentation, we will put your questions to them. Today, we are joined by Professor Ahmad Tarawah, Pediatric Hematology and Oncology Consultant at King Salman bin Abdulaziz Medical in Madinah, Saudi Arabia, and President of the Medina Hereditary Blood Disorder Society. I'd like to thank Professor Tarawah for joining us today, or rather this evening, as it is already really quite late for him. Thank you so much for spending part of your night and your evening sharing your expertise with us. I will turn things over to you now, Professor, to get us started.
Thank you, my dear. Good afternoon as the time at your place, and good evening for the people following me from my side. Let me share my screen first. Well, today I'm going to talk to you about the Glanzmann thrombasthenia, and I'm not quite sure how common it is in your place, but I know it is a rare disease among the Western nations, while the matter is different when we talk about the Eastern nations. This is my disclosure. And this is a family pedigree where there is 17 family members. They are Glanzmann thrombasthenia, and they are following with me at my clinic. And we have reported that probably 3 or 4 years ago. But now we have a family with 40 members. They have Glanzmann thrombasthenia. We are preparing to publish it. This is what I'm going to talk to you about, some of the areas where I'm going to go very quickly, some areas I'll concentrate on, and we hope you will enjoy that. Glanzmann thrombasthenia, it's almost 100-year-old disease when it has been discovered by Edward Glanzmann in 1918, and throughout years we start to know more and more about Glanzmann thrombasthenia. What is the Glanzmann thrombasthenia? What is the nature of the disease? And then the developments of more therapies for those patients. And currently we are talking about stem cell transplantation. We are talking about gene therapy in a couple of years. Glanzmann thrombasthenia, it has been reported from everywhere in the world, but it is more common among the Middle East nations, as I said earlier. Let me start with what is the Glanzmann thrombasthenia. Glanzmann thrombasthenia, it's platelet function problem. Where there is a protein, a molecule, integrin, call it whatever you want to call it, glycoprotein 2B, 3E, which is on the surface of the platelets, it is missing. Let me start with when you have a cut wound or you bleed from anywhere, this is a big process, big cascade happening in your body to stop that bleeding. And it needs integration between the platelets, coagulations, and vasculatures. And end by a clot, which stop your bleeding. I'll not talk about them. I'll talk only about the platelets. With this protein in the surface of the platelet get abandoned when you have a bleeding and activated platelets, and the function of this piece of the protein to attach each platelet to the other platelet via the fibrinogen in a process called coagulation. So we will have the primary plaque, and then the cascade will end by the fibrin filaments to stop your bleeding. This is the same in another picture. It's an autosomal recessive disease. What does that mean for you? It's a disease, the mother and the father, they should be carriers for the disease, to have the disease. And if one of them only carry the disease, the child may be normal, may be carrier only, but he cannot be a disease person. I'll not go into the detail of the mutation which has been reported in the Glanzmann thrombasthenia database. It has been reported everywhere in the molecule, in the protein, which is defected and lead to either stop the formation of the protein or decrease the formation of the protein or non-functioning protein. And this is the whole genome for the two proteins we are talking about. It's something very complex. It has been reported in the Middle East. I'm talking about the mutations, and this is the list of them. In Saudi Arabia, we have reported our data a couple of years ago, and this is the mutation in the two genes we have in Saudi Arabia, and we have 6 novel mutation we have reported, and this is the mutation we have in Medina, the city where I'm coming from, where we have reported most of the mutation in the protein or in the gene ITG A2B and very little in the ITGB3. And most of our patients, they are falling in this category. From the mutation, we have formed a geographical distribution of the mutations in Glanzmann thrombasthenia. So we know those patients coming, for example, from the east of Medina, they carry certain gene. Those coming from the south of Medina, they have carrying certain gene. This is just for educational issues. In general, worldwide, this is in 2023, there is 362 mutation in glycoprotein 2B and almost 200 mutation in glycoprotein 3A. And this is the way where the patient carry or get the disease when there is 2 couples, they are carry the disease. Let me have them in the first one, when they have 2 copies of the abnormal in this both parents, so we will have a patient whom is homozygous, carry the same mutation, and as I said, both parents carry the same gene. Well, it doesn't mean that everybody of offsprings of these parents will get Glanzmann thrombasthenia, only 25%. Again, when they have 2 different mutations, something called compound heterozygous, where the patient carry 2 different alleles, 2 different mutations, and only, again, 25%. But when we have somebody whom one parent whom is carrying the gene, he will be heterozygous, and he will be a carrier where he is asymptomatic. As I said earlier, Glanzmann thrombasthenia is very rare worldwide. It's like 1 patient among 1 million. But the matter is different when we talk about the Gulf, the Arabian Gulf. Both sides carry the higher rate, where rather than 1 in 200, it will be, 1 in a million, it is 1 in 200,000, either in the east of the Arabian Gulf or the west of the Arabian Gulf. And this is the Glanzmann thrombasthenia when we compare the Middle East to the western side of the world, where we can see very clearly it is more common among the Middle Easterns than the Western people. But look into the consanguinity rate in different countries, where we can see very clearly the Middle Eastern countries, they have carry a high rate of consanguinity marriage compared to the Western side, and this may explain the high rate of Glanzmann thrombasthenia. Let me talk a little bit about Medina, where we have 136 patients. We identified the full information in 125 patients, where the rate of Glanzmann thrombasthenia 1 in 10,000, which is the most common bleeding disorder in Medina. And it's more common than anywhere reported in the world. And you know, in the Europe, we have about 200 plus patients of Glanzmann thrombasthenia. Many of them, they are in Italy and south of France. But in my hospital, I have 136 patients. Well, it's a little predominant in females, but actually the distribution is the same. And because the tribes, most of our patients, actually all of them except one, they are Saudi in nationality. And this is the age during the study. Distribution is different from everywhere. It has nothing to do with the lifespan, but they are presenting early, the first 5 years of life, and many of them, they present within the first year of life, particularly when they have another sibling whom he had Glanzmann thrombasthenia. So we are doing a screening for those patients. 98% of my patients, they are product of consanguinate marriage. 86, they have family history of Glanzmann thrombasthenia. And 60% of my patients, they have another sibling whom he has Glanzmann thrombasthenia. 25 families, they have 2 to 5 children with Glanzmann thrombasthenia. And as I said, this is the largest family reported, and we are now studying the 40 patients in one trial. All platelet disorder, they are presenting with mucocutaneous type of bleeding, gum bleeding, epistaxis, dental bleeding. And during the puberty or the ladies, they have high rate of menorrhagia, but bruces has been found in 1/3 of our patients. The other type of bleeding, it has been reported, but it is not common as the other type of bleeding. In my series in Medina, we divide them into 3 categories according to the severity of the course of the disease, where almost half of them, they are on mild course, where we define the mild course, where they can control their bleeding at home setting, and they don't need to come to the hospital. And again, almost half of my patients, they have only 1 episode of the bleeding symptoms in a year. Again, we are comparing the symptoms from different types, the mild bleeding patients, in Iran patients, and a meta-analysis done by George years ago, where it's almost the same with little different in some areas, like menorrhagia, which is uncommon among the Iranians, but it is common among my group and the rest of the world group. As I said earlier, most of the patients worldwide, they are presenting early in their life. And we have observed that many of them, they have diminished their symptoms when they get to puberty. We classify Glanzmann thrombasthenia into type 1, 2, and variant, where type 1 is the most, where there is severe deficiency of the glycoprotein, and type 2, it is mild deficiency, and the variant, it is mostly a functional type of the disease, and this is 2/3 of my patients, they have type 1 Glanzmann thrombasthenia. And as I said earlier about the mutation and genes, there is nothing to do with the genotype and phenotype. And this is what we thought about probably years ago till 2023, when we have done our study, where we have found that there is certain mutation carry higher severity of the course, higher rate of frequency of the bleedings. So we can predict from the mutation whether they may have a severe course or not. And of course, the group is still small enough to discuss it. The whole group in this mutation study, it's about 70 or 80 patients. How we diagnose Glanzmann thrombasthenia? It is not so difficult, actually. It needs just a coagulation lab, which is prepared enough. So usually the CBC will be okay. The BFA, platelet function assessment, will be prolonged. Clot retraction will be impaired. And the other coagulation parameters will be normal. And we differentiated into screening tests where we can do it somewhere, everywhere in the centers, and we need to do something more advanced in a coagulation lab, which is well prepared, such as platelet aggregation, flow cytometry, or molecular study. And this is the platelet aggregation and flow cytometry. And usually in my place, I don't go for platelet aggregation as it is time consuming, and we need it only when there is a patient whom he is variant and the count in flow cytometry is okay, but the symptom going with the Glanzmann thrombasthenia, so we need to go over platelet aggregation or even molecular type. And this is the aggregation. As I said earlier, it is very characteristic in Glanzmann thrombasthenia, and this is flow cytometry, and this is the molecular genetic. Now, the most important part for all patients need to know, most of the bleeding in Glanzmann thrombasthenia can be stopped at home with local measures. You don't need to go for medication, transfusions, or whatsoever. Just when you have a nasal epistaxis, nasal backing, some pressure on your nose, if there is gum bleeding, tranexamic acid, which is available usually at your home, prescribed by your doctor, where you can do it mouthwash or take a pill or so. So tropical thrombin, it may be used when there is dental issues. So you can do the job at home before you go to the emergency, and in most instances, you can control it at home. As I said, half of my patients, they are doing something as such at home, and they don't need to come to the hospital. Please avoid those type of medication which affect the platelets, so you don't make the things worse. Well, iron deficiency anemia, it's a problem among the Glanzmann thrombasthenia patient where we need to recognize it, diagnose it, and treat it promptly among those patients. This is the treatment option we have: platelet transfusion, recombinant factor 7, or what we call it 7A, tranexamic acid. We'll always keep it in a stock at home of your patient or at home of your if you are a patient. Stem cell transplantation or gene therapy. It is a curative way for the Glanzmann thrombasthenia. Stem cell transplantation, now it's available and we can do it, and I'll come to that in a minute. Gene therapy, it is the future where people, they are working on it. Let me go into the platelet transfusion, where in the west side of the world, it is considered as gold standard treatment for Glanzmann thrombasthenia. When there is a moderate or severe type of bleeding, they need to have transfusion of platelets. But when we give platelet transfusion, it should be leukodepleted, single donor, HLA matched. The possible you can do in this regard to avoid the alloimmunization, which is very common among the Glanzmann thrombasthenia, as you can see in this slide. The risk of transfusion is many, simply the transmission of the infection, allergy, trali, and so on. So we decided in the east side, particularly in the Gulf, to start upfront the 7A rather than platelets, and we need to keep platelet for something more severe. 7/8 has been recognized since 1996 and shows very successfulness in stopping different type of bleeding and different type of surgeries. But it needs to be used in optimal way, particularly the first dose you give to the patient. It should be 80 or more microgram per kg in 3 doses, 2.5 or 3 hours apart between the doses. Tranexamic acid is cheap, old medication, and it is very effective, either in oral form, intravenous form, or mouthwash form. If you don't have the mouthwash form, you can use the intravenous as a mouthwash, or you can crush the tablet to be used as mouthwash. This is a study done in 2004 or published in 2015, where they compared the 7A and other modality of treatment, and it was effective. I'll not go over this study, which has been in multi countries, where they tested the 7A alone, 7A with tranexamic acid, platelet alone, or with tranexamic acid, combination of all, tranexamic acid alone, where 7A, it has been shown very effective even if given alone or if given with other medication. And of course, tranexamic acid and platelet are effective too. It depends on where you are working and the policy you are following. So in summary, 7A, it was very effective in all type of bleeding and with safe profile. Now let me take you, when you go to the hospital or when a patient with Glanzmann thrombasthenia come to you, how you manage the bleeding episode. So first of all, we need to know that this patient has antiplatelet antibodies or not. And then whether the bleeding is major bleeding or it's minor bleeding, and then we manage those patients accordingly. When they don't have antibodies and they have minor bleeding, usually conservative type of management is enough, and local measure plus tranexamic acid, and rarely we need to give platelet transfusion or recombinant factor 7. But when there is a major bleeding, you need to do the conservative and local measure and tranexamic acid plus either platelet transfusion or 7A, depend on the place where you are working in. But when you have antibodies, it is preferred not to use the platelet transfusion and to use 7A immediately in addition to the other measures. Still, if you have alloimmunization, you may use platelet transfusion in certain cases, not in case of refractoriness, of course, but there is sometimes transient type of alloimmunization. There is some antibodies which is doesn't affect the platelet transfusion. So you need to know the increment of the platelets earlier on, of course, not during the bleeding. So you know whether the platelet transfusion is effective or not. The same in the major bleeding. Surgery. When you do surgery for a patient, again, we divide them with antibodies, without, major surgery and minor surgeries. And probably this is the definition of major and minor surgery according to the surgeons. So we have to have a very well-written plan and very well coordination between the hematologist, the surgeon, the anesthesiologist, the lab, and pharmacy. And we need to have a plan pre-op, just peri-op or intra-op. And peri-op, we need to give tranexamic acid and 7A. Intra-op, we keep watch the patient, but we have the things to be ready. We can transfuse if there is bleeding. And accordingly to the type of bleeding, we go for post in minor type of surgery. Usually, we give tranexamic acid alone, may give 7A for the first day, and you space it over time. And in major surgery, the same in the pre, peri, and intra-op, but in post-op, we need to give tranexamic acid 7 to 10 days or till the bleeding stop, and we need to give 7A till bleeding stop, and we do spacing when we are going over. Alternatively, we give platelet transfusion. But when you have antiplatelet antibodies, either minor or major surgery, we need to give only 7A. And again, platelet transfusion, it can be given if we have tested before and we know the increment of the platelet among those patients and the recovery of the platelet. Dental issue. It is a major issue among the Glanzmann thrombasthenia patients. And if we have patients among us, they know that when they have bleeding in the gingiva, it is harmful. When they need to brush it, it will bleed. So they may not brush it very well. So it will lead to gingivitis. And whenever you have gingivitis, you will not brush your teeth. And this will lead to, again, bleeding, and we will go into these cycles. And this is some picture, sorry for it. Now, how we manage dental procedures among those patients? We divide them into low risk of bleeding and high risk of bleeding. The dentists, they know better than me in this regard. And accordingly, we do our management. Generally speaking, good oral hygiene. Each patient with Glanzmann thrombasthenia should visit the dentist at least 3 or 6 months frequently. And we need to do brushing like 3 or 4 times a day with the toothbrush, which is smooth type or sponge type, using the toothpaste containing fluoride. And whenever you have a problem, you need to visit your dentist and to explain him what is the going on, and he's going to prescribe you the medication. Among those patients who having the dental workup, again, low risk or high risk for bleeding, but usually we don't care about the antiplatelet antibodies, and we give 7A rather than platelet transfusion. Usually they don't need it. Tranexamic acid is vital in those cases and need to be used before the dental workup and continue till bleeding stop. If we think about bleeding among those patients whom they have procedures, we need to give 7A before and after. And if there is bleeding and 7A failed, we need to give the platelet transfusion. And again, in high risk, we will give. Now, in the low risk, we will not give 7A. In high risk, we will give before and even after till the bleeding will stop. Let me go to the gynecological issues. This is the different disorders, but look into the rare bleeding disorder. Glanzmann is one of them. It is very common to have menorrhagia among those patients. Exactly why those patients, they have menorrhagia, it is not very well known, but there is different proposal for the pathophysiology for menorrhagia among those patients. And look into this. This is a comparison between different type of bleeding disorders. Glanzmann, Thrombasthenia, they have the highest rate of menorrhagia. Among my series, almost 98% of my patients, they had menorrhagia. And as you know, menorrhagia, particularly ladies, they know that quality of life among those patients, it is affected severely. And this is the way we are monitoring BPAC, that the lady, she will monitor it. I'll not go into those details. And this is reflect on the how severe is the menorrhagia they have. And the doctor need to know about that among those patients. How we manage that? Hormonal therapy, antifibrinolytic agents, 7A, platelet transfusion, and so on. And again, it depends about the patient themselves, whether she wants to get pregnant, so we don't use the hormonal therapy or not. So we will use the hormonal therapy. And this is different regimen of hormonal therapy, which I will not go into details of them. This is the way we are doing it in Medina, where we have a protocol, we call it Medina protocol, where we have the patient into, again, two groups. Those whom they are childbearing and they want to get pregnant, we don't use hormones. If not, they will go into the other side. Girls whom they are not going for pregnancy, they will go into the protocol. And the protocol by yellow, we will use hormonal therapy for a certain time. And then at the certain point of time, hormonal therapy will stop and tranexamic acid will be started. And with the first drop, they will use a single dose of 7A. And keep watching if they need more doses of 7A or platelet. At day 5, we restart the hormonal therapy and keep going for those patients. If there is 3 cycles with heavy menstruation, we will exit them from protocol and we keep them on hormonal therapy forever. Otherwise, we continue the protocol. And in 2017, we have found something interesting, that not every single Glanzmann thrombasthenia, they need to go into the hormonal therapy and the protocol. So we add something in 2017 protocol that we give an observation period where we don't start hormonal therapy. We keep the patient just looking and observing. If they don't have heavy menstruation, they need to go to the protocol. If they have 3 consequent heavy periods, they will go into the protocol. And again, if they go into the protocol, we may give them a chance to go into the protocol, off protocol, I mean, and not use the hormonal therapy. Currently, there is 45 ladies and young ladies had menstruation, and we are following the protocol for them. And I'll go very quickly over our results. Where 22 on protocol 2014, which is hormonal therapy. 6 of them, they exit the protocol. 9 of them, they continue on with the protocol. 7, they have gone into 2017, which is just observation. They don't need to take any medication. But 2 of them return back to 2014 because they get heavy menstruation. But 16 patients, they are following no hormonal therapy. They may use tranexamic acid during period and nothing else. And they are doing that in a way, very good way. 10 ladies whom they don't follow any type of protocols, and they are doing fine. Pregnancy is another challenging issue among the patients with Glanzmann thrombasthenia. There is a high risk for miscarriages, bleeding, preeclampsia, postpartum hemorrhage, and so on. And it is common they have alloimmunization, particularly during pregnancy, and they need to manage it. In Medina, we have 10 ladies whom they had 28 pregnancies, and this is the data for them. They have 13 girls, 11 boys. For the babies, only 4 of them they had bleeding, 2 only they have intracranial hemorrhage. Thrombocytopenia has been reported in 9. 6 patients or 6 babies found to be Glanzmann thrombasthenia. Most of our patients, 70%, they have normal delivery. 30% they have cesarean. Usually based on the parent request not to have the risk of bleeding or so. And bleeding during the pregnancy, it has been reported in 7 patients, which is 20%, which is usually related to the pregnancy, while the other bleeding, it is related to the Glanzmann, but not the pregnancy. Delivery, usually in Medina, we are using the prophylaxis system. So we give 7A and tranexamic acid starting from the first phase of labor, and we keep platelet ready in case we need to give platelet for those patients. And we keep keen not to have the forceps delivery, not to have the fetal monitoring by that way. So there is a risk of bleeding in this management. Postpartum hemorrhage, again, it's common among the patients with Glanzmann thrombasthenia. And what's happened, we need to treat tranexamic acid, 7A, platelet concentrate, depending on the area you have. And this is the prophylaxis system we have done in Medina. And as I said, 64% of our patients, they had postpartum hemorrhage. And even they were in prophylaxis. And we couldn't find that there was a clear correlation between the prophylaxis and the postpartum hemorrhage. But we advise people to give prophylaxis, even if there is no correlation. Still, it is a small group, we cannot judge. Iron deficiency anemia, as I said, it is very common. Almost 2/3 of our patients, they have iron deficiency anemia, and this is their parameters. And most of them, particularly I am treating children, they are responding very well to iron alone, oral iron alone. And alternatively, we give either IV iron or both oral and IV iron. In adult, usually we go directly to the IV iron therapy. And very few patients, they may get refractoriness and they don't respond to iron therapy. Prophylaxis, there is certain patients, they have frequent bleedings and it affects their quality of life. So we thought, why not to try prophylaxis like we do in hemophilia? So we keep a temporary or short-term prophylaxis, 3 to 6 months. And this is the rationale behind it is very simple. Patients, when they bleed from the mucosa or the epistaxis, it will lead to some certain changes in the mucosa, and it leads that the baby or the child or even the adult play with it. It is itchy, so they will bleed and so on. So why we interrupt this process by prophylaxis? We give the time for the regeneration. What we have found in that study that almost all the patients, we tried the prophylaxis for them, they respond very well, and they gone after that with less bleeding and less frequencies. Alloimmunization among our patients, it is very uncommon, and compare it to the other studies coming from the western side of the world, we are the least. We thought that probably because we are using 7A as upfront medication, and we don't have that much of alloimmunizations. And the patient whom they have reported alloimmunization, almost one quarter of them, they develop alloimmunization during pregnancy. 4 patients only, they have platelet refractoriness. And the other patient, we can give, this is some sort of antibodies rather than refractoriness. This is what we do believe. Stem cell transplantation, the modality, it has been proposed in 1985, and we don't use it for everybody because it carries its own complication, late complication and early complication, infertility, mortality, growth retardation, secondary malignancies. So we don't use the stem cell transplantation among our patients in this regard. Particularly, most of them, they are mild bleeders. And this is an indication, as I said, simply bleeding that affect the quality of life of the patient, it's indication for the stem cell transplantation. This is all, sorry. This is all the meta-analysis, and what we have shown in this meta-analysis, there was 43 GT patients whom they have gone for stem cell transplantation, and probably this is the some sort of the data about the how we do it, the preparation and so on. But usually they are responding very well, Almost all of them, they are alive. I think 2 of them, they have rejected. Gene therapy, another modality which has been not studied on patient yet, or it's not going into phase 3 therapy, but we hope that will come in the coming few years. And I'll stop at this point of time, and I'll give you time for discussion. Thank you.
Super. Thank you very much, Professor. That really interesting and comprehensive presentation. It's really a special treat for us to learn from someone with so much experience with a disorder that we unfortunately hear so rarely about. So we'll go ahead now with our live Q&A. If you have any questions for Professor Tarawah, please enter them into the Q&A feature at the bottom of your screen, and we will do our best to answer all of your questions. So maybe I can start with some questions about the women and girls that you're working with. You have a really impressive approach to managing the heavy menstrual bleeding and questions around maintaining the ability to have children. And so as you developed that protocol, were you working with the women and girls and their preferences? Were you working with specialized gynecologists? Can you tell us a little bit more about how you developed that?
Well, let me tell you something. And actually, what has happened in 2011? There was the first girl had her menstruation in my center, and as the protocol at that time to keep ceasing the menstruation, so we started her on hormonal therapy, and 6 months later came again with heavy menstruation. Then I said, how come on hormonal therapy and coming with heavy menstruation? Then said, no, we have stopped the hormonal therapy maybe 2 or 3 months ago. Why? How come a girl without menstruation? Well, in the ISTH, the one in London, there was paper coming from Pakistan. They reported the same problem, and it looks like that the Eastern culture doesn't accept that the girl have no menstruation. That is why we have developed that protocol. Now, the whole protocol managed by the gynecologist and hematologist. So the gynecologist taking care of the hormonal therapies, the protocol, and so on, which we are not so familiar with. And when they have the menstruation, we take care of that part with the tranexamic acid and the 7A or platelet. And we are the one responsible about the participation and application of the protocol. Probably because Glanzmann Thrombasthenia is a hematology disorder rather than gynecology disorder. But we have a good collaboration between us and them, and usually we have a clinic, a joint clinic once every 3 months, so we can discuss those difficult cases where it is not forward cases.
Right, it's fantastic to hear about that sort of collaboration. Are there difficulties in talking about this? Is there stigma associated with menorrhagia, or is it something that the patients are quite comfortable discussing?
Again, sorry?
I'm just wondering if there's any difficulties with the conversations. I know in some cultures, certainly where I am in Canada, some people are very reluctant to talk about heavy menstrual bleeding. And so those conversations can be hard to have. Are you finding it straightforward to have these conversations with your patients, and is there also conversations happening within the community perhaps?
Well, there is one study we have conducted. It has not been published yet. We have studied 7 countries, including Canada and Saudi Arabia, China, I believe, Brazil, and so on. And it was multiple questions about the knowledge of patients and healthcare providers. One of the questions, how easy for the girls to talk to somebody about her menstruation, the mother, friends, and doctor. And we have found that sorry to say that the Canadians feel difficulties to talk about it, while Saudi patients, they were not. Probably this is related that the girl and the mother, they know about the Glanzmann very well, and they know about the menorrhagia among the Glanzmann patients, and they know about the Glanzmann from the other families and other friends, other or their siblings or so. So it's very easy for them to come and tell the doctor, hey, my daughter, she has menstruation and she has heavy menstruation compared to her sisters or cousins or whatsoever. And, she has Glanzmann thrombasthenia. Her cousin, she has Glanzmann and she has the same, and you have started here on something. So it is very easy among my patients to discuss this issue. We don't feel, they feel shy or so. They used to it. It's the same like in hemophilia when they talk about the hemarthrosis. This is a main problem for them, so they talk about it. Yes.
Yeah, that's really interesting. It really shows how the community, the strength of the community, that there's a normalization of talking about this as a matter of health, just a regular matter of health, which is really, like you say, it's quite different from, for example, the US and Canada. Another question about menorrhagia. This has come from one of our audience members. They ask if you would recommend to stop using hormone therapy with estrogen and use another option without estrogen once a woman is 35, if she has a history of severe migraine and uses tranexamic acid as needed for bleeds.
Well, I'm a hematologist. I'm not gynecologist, so I'll not be the proper person. But actually, this is the area where we quarrel with our gynecologists what to use. Estrogen alone, I mean estrogen plus progesterone or progesterone alone. At the beginning, we start to use progesterone alone without estrogen. Subsequently, we are using the combined estrogen-progesterone. And of course, for the ladies whom they are older, most of our patients, actually, they are young, teenager or 20 plus. But for those whom they are older, we use progesterone alone. I don't know exactly the rationale, if it is the migraine, but they say something about the uterine tissue or so that they need to use progesterone, not to use estrogen. Fortunately enough, those patients whom they are old, I mean more than 35, there are few of them. Still, the younger patient, they didn't reach, they don't reach the 35 or so. But this is an area, and I have found that even in WFH, the gynecologists, we keep discussing the same issue. Some people, they believe that we need to use both or progesterone alone. Still an area where myself, I don't understand it very well.
Thank you. Another question about the heavy menstrual bleeding. I was really interested to see that in your study and in the meta-analysis, you saw very high rates of heavy menstrual bleeding, but in the Iranian study, only 13%. Do you have any thoughts on why that might be so low in that study? I know it's not your study, so it's maybe a bit unfair to ask, but it just really struck me how different that was.
It was actually all the studies. It has been published in 2004, where I didn't find a chance to meet the authors whom they have published this study. It's 20 years ago. Myself, I need to know their rationale, what is happening among their patients, why they do have low rate, whether it has something to do that their patient, they don't talk about it, whether it has something to do with culture, religious, whatever, I don't know. I have no suggestion about that. But usually in these studies, coming from many places, menorrhagia is common among Glanzmann thrombasthenia or other platelet dysfunction disorders.
Right. Yeah. Another question somebody had was asking about, aside from bleeding, what are the most challenging secondary complications that your patients are facing, and how do you address these?
Side what?
So secondary complications. So how is the Glanzmann thrombasthenia affecting their lives beyond the first issue, which I suppose is the bleeding, but then going beyond that, what else is a challenge for them, and how do you work with them on those secondary sort of implications?
Well, let me tell you something. I cannot divide things into primary, secondary, something as such. Usually, the Glanzmann thrombasthenia, it's something related to the bleeding itself. And where is the bleeding is, this is a matter. Now, if somebody has intracranial hemorrhage, So it is not secondary or something as such. He has the bleeding in the brain, and the bleeding affects the brain. So he has complication of the bleeding in the brain. It's not Glanzmann thrombasthenia. If he had car accident, if he has fall down or something, and he has intracranial hemorrhage, he will have complication of that intracranial hemorrhage. It is the same when we consider any type of hemorrhage. Well, in Medina, we have maybe 5 or 6 patients, they have hem arthrosis. I mean, Glanzmann thrombasthenia. So it is not something related to the Glanzmann, it is something related to the hem arthrosis, where they have a joint chronic synovitis among those patients. So this is something related to where the bleeding is. The Glanzmann thrombasthenia, well, maybe the one who is asking the question maybe asking about, like in some disorder, there is secondary malignancy, for example. Some disorder, they end by the age of 50 or 60, some other complication. The matter is not the same in Glanzmann thrombasthenia. It's always, always, always bleeding and the complication of the bleeding. But the Glanzmann thrombasthenia by itself, probably no, I can't say that. But it's a bleeding disorder where the bleeding we have. One of my patients, she had ovarian bleeding. Well, now they need to cut her ovaries, and as far they have cut their ovaries, they cut the uterus width. So it's infertility, but due to the place of the bleed. It's not the Glanzmann by itself.
Right.
Of course, when we talk about pregnancy by itself, now we know that preeclampsia rate is high, miscarriage is high, and postpartum is high, but not something long-term complications.
What about the iron deficiency anemia? I know that's something that can sometimes result in complications that are maybe not immediately recognized as having to do with the bleeding. Do you run into any issues with that?
Well, that is why we always say for the physicians, whenever you have somebody with iron deficiency anemia, whatever the diagnosis is, you need to treat that patient. In Glanzmann thrombasthenia, iron deficiency anemia, because of frequency of the bleeding is high, so they have high rate of the iron deficiency anemia. As I said, 2/3 of my patients, they had iron deficiency anemia. And we know that there is some complication or long-term side issues in the iron deficiency anemia, in particular children. And most of Glanzmann thrombasthenia, they are diagnosed before the age of 5. So during the first, let me say, 15 years of life, they have more frequent bleeding than after. So we need to check for iron deficiency for every single Glanzmann thrombasthenia patient. And whenever we detect early signs of iron deficiency anemia, we need to start therapy for those patients. Whatever the protocol in your place, use it. And we need to correct the iron in the body of those patients because of the complication we know in the long term. So it should be managed. In particular for the children, as I said, and women, particularly during the first 30 years of life, because they have menorrhagia and so on. So we need to treat those patients. Now, for the physician, it is not that easy when we talk about the iron deficiency among Glanzmann thrombasthenia to treat. Many patients, they will have refractoriness. Whatever you give them, they will never respond. But there are few of them. But most of them, they are responding. In children, they respond even to the oral type of preparations. And in adult, now we give the IV iron therapy, and usually it is corrected.
How do you work with your patients in terms of managing what sorts of things they can manage at home and knowing when they need to come in to have a bleed dealt with, maybe in the clinic or even in urgent care? And do you have any reluctance of people to come in? I know in some places, maybe more where Glanzmann thrombasthenia is much less well known, there's some reluctance to go to the ER because their disorder is not well known there. And you've got fantastic collaborations, it sounds like, with the gynecologists and the dentists. I don't know if you have similar relationships with your emergency physicians and a raised awareness there, but can you talk to us a little bit about how you manage that with your patients?
Well, let me tell you, the hospital I am working in is very, very busy hospital. probably one of the busiest in the country, where the emergency room, it is very crowded, and whenever somebody going to emergency room, they need to wait for a while. Where we teach all the patients we have, particularly those whom they have frequent bleeding, what they can do at home before they are coming to the emergency room. So if they can stop and manage their bleeding at home and not to come to the hospital, this will be perfect. And as I said, half of my patients, they do so. They can manage, they have tranexamic acid stock at home. They have the local, the thrombin, or what we call it, fibrin glow or so. And they know the practice how to hold or do nasal backing or just do pressure or so. So they are doing that. And from the society I'm working in, we are doing frequent workshops for the patients where patient whom they know what to do, they teach patient whom they don't know. So not the doctor, but the patient teach the patient. And last year, we have started a new protocol where we have agreement with a company that even those patients who they have moderate type of bleeding, somebody will go at home and give them the first dose of the 7A or even the 3 doses. If the bleeding doesn't stop, they need to go to the emergency. So we reduce the number of patients admitted to the hospital. We reduce the number of patients they are going to the emergency room. And again, we are doing workshops for the emergency room healthcare workers to know what is the Glanzmann thrombasthenia, and those patients need to be an emergency issues, and they don't need to wait. But they try their best, but it is sometimes it is difficult because there is a lot of people waiting. But usually we teach our patient what need to do at home rather than to go to the hospital.
Great, thank you. Someone's asked about the criteria that you use to choose whether you're going to send a patient for BMT, and I would understand that to mean a bone marrow transplant. Does that sound right?
Look, when you compare somebody to do transplant and get rid of Glanzmann thrombasthenia and he will be cured, or not to do it. Now, how you can judge something as such? Everybody knows that transplant by itself carry a lot of complication with it on the long term or acute. This is not the time where I can speak about the transplant by itself, but it is a process, long process. They need to use chemotherapy, maybe radiation therapy, blah, 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 a lot of things. They need a donor and so on. Then somebody whom he is bleeding once a year, why I need to ask him to go for transplantation? Now, somebody, he's bleeding like twice a month, and he need to get absent from the school or from the work. So this is severely affecting his quality of life. This is an indication for transplant, where I cannot live with the Glanzmann bleeding, so I need to do something. Transplant will be good for those patients, and we have, I think, 3 patients, they have done transplant and they are doing fine. In the Gulf region, there is 9 patients, they have done transplantation, and again, they are doing fine, and the result is good. Particularly in the Gulf, we are doing the not haplotype, but full match transplant. And again, I am not transplanter. But again, it depends on the quality of life of the patient. Those whom they have quality of life has been affected severely by Glanzmann bleeding, they will go for transplant. Otherwise, I believe it is not. In many occasions that we propose it for the patient as part of the management, but we do not recommend it for your baby, for example, or for you. So just I need to tell you that there is something, but you don't need to do something because 1, 2, 3. And usually they don't choose the transplant.
Okay, that's interesting. That sounds like a very much a shared decision that you take together.
Yeah.
Somebody else has asked about research into prophylaxis for Glanzmann thrombasthenia patients. There's a new biotech company maybe doing this work. Are you aware of this? Is there anything that you know about this?
I'm aware, but I'm not authorized to talk.
Okay. That's an answer.
Let me talk about the prophylaxis we are doing. So, there is a company actually working on prophylaxis molecule. I hope all success for them. It's something very important for Glanzmann thrombasthenia patient. The prophylaxis we are doing is something different. It is depend on 7A. We are giving that every other day, 270 microgram per kg, and it is short term, 3 to 6 months. And it has been effective in those patients whom they have a problem. And all of them, after the prophylaxis, they are getting very well. And none of them, we need to do the prophylaxis once again, for example. But what you are talking about is something different. It is something like the prophylaxis we are doing in hemophilia, for example. It is something carries some hope for our patient, and I hope in the coming few years it will be in the market.
Great, thank you. That's exciting. Maybe just another question, and I really have to ask you to forgive my lack of knowledge here. Maybe you can tell us a little bit how in Saudi Arabia healthcare and access to medication is paid for, and whether there are any issues with people and having access to the specialized care and the therapeutics that they need for the treatment of Glanzmann's thrombasthenia. I know in the US that can be an issue.
Well, except for the transplant, the whole package of management is available for everybody. And it's divided. Either it is governmental assurance or it is private assurance. So everybody has assurance, and they have the right to go for any hospital and get managed in both ways. I cannot say that some patient they don't have insurance. We as a patient society, we can do it for them. It's very rare because only one patient whom he has not local, but all the local patients were 135 patients of ours, they are Saudis. So all of them, they go for the governmental type of insurance. And very few of them, they go for the private company insurance. And that is why we don't feel that we have a problem. Of course, for the Saudis, they are eligible for transplant. For those whom they are non-local, it depends on the insurance they have. If it is the full insurance, they are eligible. If it is not, they are not eligible. Well, to date, I didn't hear from my colleagues that we have faced this problem with any body of our patients.
Great, thank you. We had a question come in asking whether you know of any cases of atrial fibrillation in a Glanzmann's thrombasthenia patient, and if so, if you think that the patient could be treated with cardiac ablation, which requires anticoagulation therapy before and after, or to be defibrillated. So I don't know if you've come across any cases of people with atrial fibrillation and Glanzmann thrombasthenia.
Okay, I am pediatrician, so I don't come across those type of patients, alhamdulillah. But yes, there are people like every other people. They can get any cardiac problems, including the atrial fibrillation, and the management will be the same. Now you will ask, the defibrillator may cause some sort of process or so, but even if non-Glanzmann, it will do the same. And we can do it for them, and we can keep watching those patients. Of course, everybody have atrial fibrillation. We will keep watching them. And only one patient of whom I am following, I know that he has cardiac problem and he needs surgery. The problem that he has platelet refractoriness, and this matter, it does affect the decision for the cardiac surgeon, even for the hematologist, to take this patient for surgery. But any other patient whom they have something as such, we can manage them like any other people. From the group I am following, none of them has gone into something as such. So I don't have enough experience in this regard. And again, I am not a cardiologist, but if a cardiologist asks me, shall I do defibrillation for this patient, I'll tell him yes.
I guess maybe related to that question is, and as people with, for example, hemophilia are aging, they're running into more instances of disorders with age where anticoagulation therapy would normally be the therapy of choice. Are you having any questions about balancing that need with your Glanzmann Thrombasthenia patients? How would you approach somebody who has something where normally you would treat with anticoagulants, yet they have this bleeding tendency?
Well, it's the same like every bleeding disorder. It's not something related to the Glanzmann by itself. It's the same in hemophilia. When you have somebody, he need to be an anticoagulant, particularly that we have older patients, whether in Glanzmann, hemophilia, other bleeding disorder, and they may need to go for the anticoagulation. There is protocols or guidelines proposed probably last year or the year before about how to manage a patient with bleeding disorder and with anticoagulation induced patient. It's something big enough that we don't have enough time to go over it. But yes, we can do and we can anticoagulate, but there is special precaution among those patients. We need not to do it like when we do it in the other patient, like DUAC, for example, we use it in the other patient usually. In Glanzmann thrombasthenia, in hemophilia, in other bleeding disorder, we need to be very careful among those patients, but it is not contraindicated.
Great. Thank you very much for that. Well, we could keep going all night with all these questions, but I'm afraid we will have to bring this to a close. Thank you so much, Professor, for answering all of these questions. We really appreciate you being here with us today. I'd also like to thank everybody in our audience for joining us. This recorded webinar will be available at hemophilia.org shortly after the webinar. You can go to the NBDF website, and under the Events tab, if you select Past Events, you can find all of the archived webinars there. Thank you so much for joining us this afternoon and this evening. Have an excellent week.